I'm from Florida. Welcome to Florida. The objective today is to screen patients who have underlying sleep pathology. I want to tell you a little bit about myself. My name is Dr. Jose David Suarez. I'm a family physician. I'm the program director at Westchester General Hospital. I have a resident here visiting. Thank you. We take them out on health fairs around the community. I think that's really important. I have no financial disclosure. The only disclosure that I have is that not only am I going to speak to you about sleep disorders and screening of sleep disorders, but I am also a patient of sleep disorder. I have obstructive sleep apnea, and what was interesting in my case was that I really didn't present with the classical choking and snoring, but I just didn't feel right. Being, of Spanish descent, I actually thought that I was supposed to take a siesta during the middle of the day, and I was basically just running out of gas. So I was tested, and sure enough, I sleep with a ResMed sleep apnea machine, and I actually feel great. It's actually could change your patients' lives. So the most important thing here is for you to be aware and be able to recognize who are your patients. And the most important thing is that probably a third of the patients that you touch that come right into your office probably have some type of sleep disorder. So one of the most important things is to develop that clinical eye when the patient comes in, that you could start screening them from the beginning. The minute they walk into your office, you could say, that patient looks like he has some sort of sleep disorder, and you will learn have certain tools available to you to be able to appropriately screen these patients. Sleep disorder screening. I don't always feel really awake, but when I do, I should be sleeping. It's a funny slide, but it's true. More and more patients and people around the world are not sleeping. We're sleeping less and less. And this is actually a huge problem. Could you imagine that 40 million people in the United States are unaware of having a sleep disorder? Over 70 million people in the United States have a sleep disorder. And actually, the CDC has declared that insufficient sleep is a public health problem. The average American sleeps between 6 and 9 hours a day, but you should be sleeping between 7 and 9 hours a day. That's the recommended. Shaving off 1 hour of sleep could be detrimental to your health. So, all of you that are physicians and healthcare providers, if you're not sleeping, we actually cut corners, and it's like, gotta get to the office, gotta run to the hospital. If you're shaving off time, you're actually hurting yourself, and you're aging faster, and you're at risk for hypertension, diabetes, and just an entire multitude of medical issues. A third of all Americans are not sleeping. So that's why I say when a patient comes to see you, you could probably say, you're probably not sleeping well enough. You're just, you're cutting off, you're overweight, or you have diabetes, or your testosterone is too low. Maybe you have patients that come in and don't feel well. You have to screen them for sleep disorders. This is the economic impact of sleep deficiency. It's not just an American problem, it's a global problem. If you see here, I hope this is the pointer, right here. So if you see here, these are the GDP. So this is basically the percent of the entire economy of a country on how much they lose when it comes to sleep deprivation. So imagine the United States, 2.28% of the GDP is lost in patients with medical problems and lack of, unable to go to work, or car accidents, complications that occur from sleep deprivation. Before texting, sleep deprivation was probably one of the most common causes of car accidents in the United States. Now with distracted drivers, texting and being on your phone is probably, it is the #1 cause of car accidents. But imagine, this is a huge, huge amount of money for countries, and it's just because people are not sleeping well enough. There's another part of the economy, which is the $30 billion industry of sleep. So everybody's getting into the business of sleep. There's dentists that are selling mouthpieces for snoring. There's pillow companies that are out there, claiming that their pillow is better for anybody, for people to sleep better. Mattresses. So it's a huge industry. There's also supplements, melatonin, drops. So sleep is a huge industry in the United States and across the world. So they did a study, and they actually said, let's take these volunteers and let's restrict 4 to 5 hours of sleep just for a few days and see what happens. This was only a few days, and in a few days they were able to see worsening of their neurocognitive disorders. So basically what was happening is that these patients were having dementia-like syndrome. They had memory problems. They increased their depression, increased anxiety, become irritable. They were having metabolic disorders. Their glucose tolerance tests were off. If they were diabetic, their diabetes was worsening. And their immune system was actually also being altered. They noticed a decrease in testosterone level. That's why it's so important when you have a patient and you check their testosterone, think of sleep disorder, think of obstructive sleep apnea, because they may have this. The bottom line is, when you have a patient and they have a medical condition, you have to check their sleep status. You have to do a sleep inventory to see how are they sleeping. All these pathologies worsen when you don't sleep right. If you don't regenerate and you're not sleeping adequately, your diabetes is going to get worse. Your blood pressure is going to get worse. Or your anxiety is going to get worse. Depression. So one of the most important things is recognizing, and like I say, developing that clinical eye to be able to look at your patient and say, you may have a sleep disorder. What was interesting is that not only were you having all these behavioral neurocognitive abnormalities, but you were at risk for infection. Could you believe that you have an increase of pneumonia if you're not sleeping appropriately? So that was just a few days. Just a few days. These volunteers were studied, and they noticed that all these medical conditions were occurring. So imagine, shave off an hour every day, hour and a half. It's, oh, I got to do this, I got to go do the wash, I'll go to bed instead of 11, 11:30, 12 o'clock. And what happens is, you now have chronic sleep deprivation. So you're at risk for diabetes. You're at risk for cardiovascular disease. You're at risk for cancer. You're at risk for increased mortality, sudden death, heart failure, CHF, the list goes on and on and on, depression, impotence. It just increases. So the most important thing is to be able to recognize your patient. So how do we classify sleep disorders? The International Classification of Sleep Disorder 3, so this is an organization that got together and said, let's classify it. And they basically classified it in these 6 broad segments and basically said, okay, so insomnia is one, and 10% of the population suffers from insomnia. Probably, and that's actually a pretty conservative figure. There's probably a lot more that suffer from insomnia. Sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnias, and sleep-related movement disorders. So how do you recognize insomnia? So basically, one of the definitions of insomnia is difficulty initiating or maintaining sleep, and you have daytime sleepiness. So the patient will tell you, I don't sleep well. Well, how does that affect your life? I get very sleepy during the day, especially after lunch. Even though there is a natural circadian rhythm that you have, that most patients actually do feel sleepy around 2 o'clock in the afternoon, which is like a normal circadian rhythm that we have, but they have exaggerated problems with somnolence during that period of time. And they're not able to nap. So it's not like they could just take a nap and recharge. They don't feel refreshed. And it actually leads to daytime impairment. There are risks for accidents, there are risks for falls, and basically it alters their activities of daily living. And, gotta go back here. So basically, what happens to the patient is that they have problems with memory, concentration, attention. Then they start worrying about sleep. They come to your office, I can't sleep. They start having mood disorders, irritability, and depression. I think that a large percentage of patients have insomnia, and a lot of times they don't even talk about it. They don't even recognize it. They just say, no, I don't sleep well, but I function okay. In my particular case, when I was diagnosed with obstructive sleep apnea and I started sleeping with the CPAP machine, about a week or two later, I just started feeling, it was an amazing feeling. I was charged up. I was like, I can't believe this. I don't know how my life has changed, because basically patients just get used to how they live. They think they're getting older, they feel that this is the way it's supposed to be, or I'm out of shape. So some patients don't even know how much their activities of daily living are being altered. So sleep-related breathing disorder. So this is another classification, and under the sleep-related breathing disorders, sleep apnea is divided in obstructive and central. You also have snoring, which is part of the sleep-related breathing disorders, upper airway resistance syndrome, and one of the most important things when your patient comes into the office is recognizing who's in front of you. And phenotypically, you could notice certain things. If you see here, it says, the doctor found out why I snore so loudly, obstructive sleep apnea. And she says, so in English, that's inner neck fat. And he says, I prefer the way he put it. So it's a funny slide, but basically it's true. If you have a patient that has a neck size of 17 or greater, they have a large percentage, they have a 50% chance of having sleep apnea. And as the size increases, the risk for obstructive sleep apnea is there. In a woman who has greater than 16 inches on neck size, they're at risk for obstructive sleep apnea. So when you see your patient, look at them and evaluate them, and look at their airway, look at their neck. Some of them, you don't have to be obese. You really don't. It's not like, oh, you're overweight, so you probably have sleep apnea. There's lots of patients that suffer from obstructive sleep apnea or sleep disorders, especially when it comes to the upper airway resistance syndrome. There are children. It's just the way their throat collapses and the way the anatomy is, and it causes obstructive sleep apnea. People that have triangular faces, people that have misaligned jaw, people that have little chins. Equal, and this is equal in male and female ratio. Deviation from any normal upper airway, so deviated septum, people that just are mouth breathers and can't breathe through their nose are at risk for these sleep-related breathing disorders. How do you recognize obstructive sleep apnea? Okay, so snoring is huge. In my particular case, I wasn't a very loud snorer, but I did snore. You will notice that the patient does not snore rhythmically sometimes. They snore, and then there's a pause, and it seems like they're gasping for air and choking. So sometimes you should just ask the patient, how's your snoring? Is it rhythmic, or is it a choking? You can't hang your hat on that when it's rhythmic, because you could still be rhythmic, have a rhythmic snore. But from moderate to severe sleep apnea, it's that snoring, they stop, and then they start breathing again. Those are your classical obstructive sleep apnea. So the gasping and choking, excessive daytime sleepiness, people feel tired throughout the day. Small jawbone, obesity, again, 17 for male, 16 inches in female. Patients that may have allergies, that have rhinitis, they may have nasal polyps, people that have acid reflux. But it's interesting that with the acid reflux, if you have obstructive sleep apnea, it can get worse, but your acid reflux usually gets better once you correct the obstructive sleep apnea. Smokers are 3 times at risk for obstructive sleep apnea. So if you have a smoker, hopefully they quit smoking, but screen them for obstructive sleep apnea. Other comorbidity, patients that come into the office and they tell you, you know what, I want to check my vitamin D because I'm feeling run down, I don't feel the same, that have decreased libido. Screen them for obstructive sleep apnea, for sleep disorders, because they probably are suffering from some sort of OSA. I remember having patients that would come in and their testosterone levels were really low, and I just got into the habit of screening them and then testing them, and sure enough, a great percentage of those patients end up having obstructive sleep apnea. If you just give them the testosterone, you're not resolving the problem. You have to treat the underlying pathology. And if the underlying pathology is that they're not regenerating and not sleeping enough, you're never going to really increase their testosterone level. You're at risk for diabetes, you're at risk for hypertension, and a host of other medical problems. Okay, so central sleep apnea. Central sleep apnea, you're going to see this in males, and you're going to see this in patients over 65, but not really. I actually have a really interesting patient who has this it's really difficult to diagnose this patient, and the patient has problems sleeping. Actually sounded a little bit like narcolepsy, obstructive sleep apnea, but really didn't fit the mold. And she actually ended up, we did an echo on her for some other reason. She ended up having a patent foraminal valley. So she has a PFO. And this PFO basically worsens and predisposes you to central sleep apnea. So that was actually pretty interesting. Also, patients that have AFib are at risk for having central sleep apnea, so you should be careful with that. If you have an AFib patient that tells you that they're having difficulty sleeping, I think you should screen them and test them for central sleep apnea. I don't know how many of you go skiing, but living in high altitude basically predisposes you to central sleep apnea. I remember going to Breckenridge in Colorado, And the first night was terrible. I just couldn't sleep. I was up all night. And actually living in California, that happened to me, was living in the mountains. And that also happened for like the first week. Then once you get used to the altitude, then you start sleeping better. But patients that go up in altitude are also at risk. Patients that have had strokes, CVAs, those are also patients at risk for central sleep apnea. And this is the central disorder of hypersomnolence. So basically the hallmark is EDS, is excessive daytime sleepiness. The narcolepsy has basically divided into two, type 1 and type 2. Type 1 is with cataplexy, and type 2 is basically no cataplexy. And then there's idiopathic hypersomnia. I don't know if you guys seen on TV that medication that comes out now for non-24 for patients that are blind, and that is basically circadian rhythm sleep-wake disorder. And what happens there is that patients, we all have a biological clock. You know, we say that you should sleep between 7 and 9 hours. Some patients a small percentage of patients may feel refreshed maybe at 6.5 hours, 6 hours. And that's their internal biological clock. These patients, actually what happens is they nap throughout the day, maybe 4 or 5 times, and that's enough, and it refreshes them. So this is an interesting syndrome, and it's circadian rhythm sleep-wake disorder. These are parasomnias. Parasomnias are basically movement and abnormal behavior. So if a patient comes into your office and tells you that they have a parasomnia, for example, they sleepwalk, they may do something that's odd. Actually here, there's actually also sexomia. They do things that actually they're totally unaware of the next day. So it's movement and odd behavior. They'll have confusional arousal. They may get up, like kids. I remember trying to wake up my kid, and I have a conversation with him. The problem is kids are actually at risk for, it's very common in children because their brain is not fully developed yet. So I remember having conversations with my son, get up, go to school, and it's like, I don't remember that. Now he's 20-something, so he can't pull that on me. But it's very common in children, especially when it comes to sleepwalking, sleep terrors, and there's also sleep-related eating disorders. I don't know if you guys have used Ambien in the past with some patients and have ever had this experience, but I had a patient who was on Ambien and would get up in the middle of the night, raid the refrigerator, do things in the house, go back to sleep, wake up in the morning and think that somebody robbed her house, that somebody came in and started eating out of a refrigerator. Long story short, it was the medication that she was taking, the Ambien, which actually gave her this sleep-related eating disorder. So we have to be very careful with certain medications, which actually can make matters worse at times. Oh, wait, sorry. So basically, the parasomnias are divided into two, non-REM related and REM related. This is what you're basically seeing in non-REM, and this is basically what you're seeing during REM. You could have sleep paralysis, and you have these nightmare disorders. So more of the sleep-related movement disorders, you're going to have restless leg syndrome. It's an urge to move your legs. They're partially relieved with movement, and these are treated with dopamine agonists. I've actually had patients with restless leg syndrome, and they're just phenomenal how they work. We also have bruxism. Patients will come in, and sometimes they walk, that's when you're grinding your teeth in the morning. Some patients wake up with headaches. and jaw pain. So that's something that you should also evaluate when a patient comes in with bruxism. So some of the important screening tools, what's not here, and I would like to add for you guys, are three things. Number one, there's the Berlin questionnaire. These are all for obstructive sleep apnea. So you have the Berlin questionnaire, you have the stop bang, and you have the OSA 50. The one that I like is the stop bang for obstructive sleep apnea. So it's stop, S-T-O-P, bang, B-A-N-G. So it's a mnemonic, and S is for snoring. So you'll ask the patient, I'm going to do, so we'll do the questionnaire that you'll ask the patient. So stop, bang. S, snoring. So you ask the patient how, if they're snoring at night, if they're gasping. The T is tired. Do you feel tired throughout the day? The O is observed apnea. So if their wife or their significant other tells them, it looks like you're gasping for air in the middle of the night, you're sleeping and it looks like you're choking, that's the O, so observed apnea or observed choking. The P is pressure. Do you have hypertension? Patients with hypertension are at risk. B is BMI. So is your BMI greater than 35? So if the patient's BMI is greater than 35, they're at risk for obstructive sleep apnea. A is age. Age above 50, you're at risk for obstructive sleep apnea. Many patients that are in their 60s, 70s, and 80s are very high risk for obstructive sleep apnea. N, the N is neck size. Is your neck size greater than 17 or 16 in women? And G is gender. Are they male? So that's actually a pretty simple screening test that you could just remember, stop, bang, and ask your patients. So history is very important. So I think that one of them, So history is important. You have to get a good history. You ask the patients for a sleep diary, basically just a couple questions, and you know that the patient probably has some sort of sleep disorder. Phenotypical characteristics, that's key. How does the patient look? Is short, stocky individual with a short neck, little jaw? That patient probably has a sleep disorder. We also want to do a polysomnograph to evaluate. These are other screening tests, and we're going to talk about that in a second. There's also the multiple sleep latency test, and that's actually done for narcolepsy, and that's usually done right after the sleep study that you do this MSLT. The MSLT is basically it's like a 7-hour test after the sleep study, and that evaluates narcolepsy. You want to get patient logs, and these basically actigraphy, which is a device that you put on your wrist, and it detects your sleep pattern, and it's a lot of people are wearing something similar like their Fitbit. Could give you a lot of information, but that is totally not a substitute for a good sleep study at the sleep lab or a home monitoring device. You want to evaluate the patient. You want to get a good history. Does he snore? Do you often have to wake up during the night? A major problem that I see in the elderly patients is that they have to get up to go to the bathroom. They may get up 5, 6, 7 times. Those patients are suffering from a sleep disorder. Do you feel tired during the day? Do you find yourself falling asleep while driving or while at work? It's funny, the patient that had this central sleep apnea, narcolepsy type syndrome would basically just sit there at a red light and fall asleep. and somebody would honk their horn, and then they would get up and she actually said, oh, I kind of felt refreshed for those 30 seconds. Do you have itching or cramping feeling in your legs? Patients that may have restless leg syndrome, they wake up with aches in their legs in the morning, they may not even know it. Do you wake up with a headache? Or a patient that comes in, you know what? I wake up and my mouth is really dry. They probably have obstructive sleep apnea. I mean, there's other causes of waking up with a headache, but this is low-hanging fruit. Sleep, probably bruxism, some sort of sleep disorder, and they're waking up with a headache. These are some of the other scales that you could use. I just put these up there so you could see. Maybe you want to, you can find this in the internet and download it. But there's the Epworth sleepiness scale. You could do this test. The one that's pretty complete is the sleep disorder questionnaire, because the sleep disorder questionnaire talks about excessive sleepiness. It also sleep schedule and sleep hygiene, insomnia, movement disorders. So you're doing a screening for movement disorders, parasomnias, and then you get your past medical history here, and social history. If you're a smoker, boom, that you want to screen for that. So that's actually a pretty neat screening tool that you could use if you want to be very in-depth. But you're going to pick up, just using stop bang, you're going to pick up a lot of pathology just with a screening test, and just getting a good history and examining your patient, developing that clinical eye where that patient looks like, boom, that patient looks like he may have sleep apnea. Okay, so this is basically the polysomnogram. I had to wear this too. I actually looked like I was going to Mars or something. And this is how the patient is all wired and hooked up. It's usually a 12 lead, a 12 channel polysomnogram. And what it does is it basically checks, it does So it does an EEG, it checks your eye movement, EOG, EMG, so it checks your muscle movements, EKG, your heart rate, and your oxygen saturation. So when you look at this, that's what basically they're monitoring. One of the biggest problems going to a sleep lab, and I actually went to a sleep lab, and I have patients that tell me, I can't go to the sleep lab. Whenever you go to a hotel or you go to, you sleep somewhere else, you have this like primitive sort of instinct that you have that protects you, and it's called the first night effect. The first night effect, I don't know if you've heard of the first night effect. So most of you, when you got here to the hotel this weekend and you went to bed the first night, you probably didn't sleep well. And it's sort of like a protective mechanism that we have that protects us from our surroundings. When you sleep in an environment that you're not used to, that's a phenomenon that occurs, and it's called the first night effect. So a lot of times when patients go to a sleep lab and they sleep outside their house, they suffer from that first night effect. What's interesting, we're really moving. There were 4,700 sleep labs in the United States. These numbers are starting to go down because insurance companies are not paying for the sleep. They prefer, if you have moderate to severe sleep apnea, they prefer to do the home unit. And that basically checks, and we'll go over what the home unit does. It doesn't really get all these parameters. The good thing about a sleep lab is that I totally recommend, if you're going to have this done, unless it's a slam dunk, you know the guy has sleep apnea, he looks like sleep apnea, he's acting like sleep apnea, it's sleep apnea. Sometimes I wish I could just give him the machine so he can sleep that night instead of like doing the whole insurance process, which is a pain in the neck. So the good thing about doing this test is that you could do a split study. So you could basically write on your prescription, you know, obstructive sleep apnea, you send them to the sleep lab, and then you order a split study. So what they'll do is, once they make the diagnosis, the technician that's there could start fitting the patient for, are you going to use nose pillows? Are you going to full face mask? I use pillows, which I love the pillow. It's simple, the nose pillows. It's just not that big thing that's up against your face, and it's not blowing into it. That's me personally. I have patients and friends that use the mask and they love it. But me personally, I love the nose pillows. So you could then, in the sleep lab, you could then tailor the treatment to the patient, and the patient gets everything one night. And then within a couple of days, you'll have your machine. The alternative is to do a home sleep study. So basically what they're doing is they're basically measuring your flow here, the oxygen saturation, and your chest expansion. So this is the home study, and a lot of insurances are actually paying for this, and Medicare actually also reimburses for some sleep studies. And this is actually okay for moderate to severe sleep study, but I personally would encourage, if you could do it, to have the entire polysomnogram done. So basically the take-home message of this talk is